All right, today we're jumping into the PET 8 trial to tackle a question that I know comes up in my clinic and probably yours too. You have a patient with stage 3 colon cancer, they're ready for adjuvant chemo, but then you see their med list, and it's long. Does that long list of pills for everything else actually hurt their cancer outcome?
8. That was the median number of other drugs patients were taking right alongside their chemotherapy in this trial. Just think about that for a second. More than half of these folks were juggling 5, 10, sometimes even more extra medications. This isn't some fringe issue. For our patients, this is the reality.
And that leads us right to the heart of the matter. We all see these complex patients, and there's always that little voice in the back of your head wondering, is this polypharmacy a major red flag? Could it actually be undermining the curative intent chemo we're prescribing? Well, this study tried to get us a real answer.
So here's how we're going to break it down. We'll start with the big question itself. Then we'll peek inside the PTAC 8 analysis. After that, we'll look at a really interesting finding, the number of meds versus the type of med. Then we'll explore toxicity as a possible explanation, and we'll wrap it all up with the clinical takeaways for your practice.
We're all pretty good at accounting for a patient's comorbidities, their heart disease, their diabetes. But what about the specific impact of the drugs they're taking for those conditions? That's always been a bit of a clinical gray area, especially when we're talking about adjuvant therapy.
We all kind of intuitively worry about it, right? Drug-drug interactions, maybe the polypharmacy is a sign of general frailty, but there just hasn't been a lot of hard data to guide us in the adjuvant colon cancer world. So this study really aims to fill that void using a pretty fantastic data set.
And it's really important to know where this data is coming from. This isn't some small, single-center chart review. Nope. This is a post-hoc analysis of a major phase 3 clinical trial. And that source is exactly why we should be paying attention to these findings.
So they looked at over 2,500 patients. And what's great is that this is a really clean cohort. Every single one had resected stage 3 colon cancer, and they were all getting a standard FOLFOX-based chemo regimen. That homogeneity is a huge strength because it let the researchers really zoom in on the variable they cared about, those other medications.
So what were they looking for? Well, the two most important endpoints you can ask for in an adjuvant trial: disease-free survival and overall survival. These are the hard outcomes, the ones that really tell us if something is having a clinically meaningful impact on our patient's prognosis.
Okay, let's get to the results. And this is where things get really, really interesting, because the analysis revealed this very clear and I'd say pretty surprising split in what actually matters.
Here it is, the first major takeaway. It turns out that whether a patient was on 2 meds, 7 meds, or 12 meds, it had no statistically significant impact on their disease-free or overall survival. This is huge. It suggests that polypharmacy itself might not be the independent bad guy we've been worried about.
But, and this is a big but, the story completely flipped when they stopped counting the pills and started looking at what the pills were. After they adjusted for all the usual prognostic factors we know about, one specific class of drug just jumped off the page: anticoagulants. Their use was independently predictive of worse outcomes.
Let's look at the actual numbers here. For disease-free survival, the hazard ratio was 1.29. And for overall survival, it was almost identical at 1.28. So what does this mean in the clinic? It means that patients on anticoagulants had roughly a 30% higher risk of both their cancer coming back and of death. And that's even after accounting for other factors. This is not a small signal.
So the obvious question is, why? Is it just that patients who need anticoagulants are sicker in general? Maybe. Or is there something more direct going on with the chemo itself? Well, the data on how well these patients tolerated treatment gives us a really compelling clue.
And here it is, the potential smoking gun: toxicity. Look at this. Patients who were on anticoagulants had significantly more grade 3 or 4 side effects from their chemo. We're talking almost 76% of them, compared to about 65% in the other group. That is a real, clinically meaningful difference in how sick the chemo made them.
And this extra toxicity wasn't just, a rougher ride. It had direct consequences on their treatment course. The rate of stopping chemo early because of side effects was way higher in the anticoagulant group. Almost 18% of them had to stop therapy, versus less than 11% of the other patients. That's a lot of missed chemotherapy.
So the paper proposes this very clear, very logical chain of events. Taking an anticoagulant seems to mark a patient who is more likely to get severe toxicity from FOLFOX.
That toxicity then leads to them stopping treatment early, which of course compromises the effectiveness of a potentially curative therapy, and that ultimately leads to worse survival. It all connects.
All right, so how do we take all of this and apply it? What does this mean for that next patient with stage 3 colon cancer who walks into your clinic on Monday morning?
I think it boils down to 3 key points for our practice. First, don't let a long med list scare you into undertreating someone. The number of drugs alone isn't the problem. Second, you absolutely should flag your patients on anticoagulants as a high-risk group, not just for their other health issues, but specifically for their ability to tolerate chemo. And third, because they're high risk, these are the patients who need us to be extra vigilant. We need to watch them like a hawk for side effects so we can manage them proactively and keep them on their plan to treatment.
And this is exactly the note the authors themselves land on. It might not be the anticoagulant itself that's the villain, but it's a huge signpost that points to a patient who's more vulnerable to chemotoxicity. And that toxicity is what disrupts treatment and ultimately hurts their outcome.
But this leaves us with one last, really critical question. The data from this trial is from a time before DOACs were common. This was the era of warfarin and heparin. Today, our patients are on completely different drugs with different safety profiles. So the big question for us now is this: does this same risk of toxicity and treatment disruption still hold true in the DOAC era? Or has modern medicine maybe helped solve this problem? That's the thought we have to carry with us from this study to the clinic.